Welcome to the Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in today's episode, we discuss BPH, or benign prostatic hyperplasia, a problem affecting over 40 million men in the U.S. alone. About 40% of men suffer from BPH by the time they reach age 50, and that number goes up to 70% of men as they reach 80. Joining us today to help us better understand BPH is Dr. Matthew Bowie. Dr. Bowie is a board-certified and licensed urologist. He graduated from the Franklin and Marshall College in Pennsylvania and then attended the Yale School of Medicine in the Medical Scientist Training Program, where he earned both his MD and PhD degrees. Subsequently, Dr. Bowie completed both his urology residence and a fellowship in laparoscopic, robotic, and minimally invasive urology at UCLA. After completing his training, Dr. Bowie joined the faculty at the Mayo Clinic Scottsdale in 2005 as an assistant professor of urology. He then subsequently returned to Los Angeles, where he has been in private practice ever since. And with that, I bring you our conversation with Dr. Matthew Bowie about BPH. Hello and welcome to the Better Man Clinics. Today we're going to be talking about BPH, or benign prostatic hypertrophy, a condition of the prostate that affects over 40 million men in the U.S. alone. That's about 40% of all men over age 50, and believe it or not, 70% of men over age 70 that suffer from this condition. And who better to talk to about this than Dr. Matthew Bowie, a licensed and certified urologist who sees patients with this condition on a daily basis. Dr. Bowie, welcome to the program.
Thank you. Thank you for having me.
Awesome. So we're going to dive right into it. The first thing that I think most of our listeners and viewers want to know is, what is the prostate? You know, the prostate gets a bad rap. Whenever we hear about it on TV or online, we hear about it in terms of bad things like prostate cancer, or even like today where we're talking about a urinary problems that it causes for BPH. But what is the prostate and what does it do?
So the prostate has a very important function, and its primary function is in reproduction. So the prostate makes the semen, the fluid that carries the sperm, and is important in reproduction. So without it, you know, there's no such thing as procreation. So that's its main role. Once and so that's its main purpose. It's sort of like a uterus, and but the prostate grows at 2 times in our lives. It has a growth spurt at puberty, which is responsible for its maturity. And then it has another growth spurt at later stages in life when a man reaches his 50s and 60s. And we don't understand the evolutionary purpose of this second growth spurt, but it's responsible for a lot of the problems that you've just described. You know, the issues that the men deal with. So it's a very prevalent and problem. And it usually starts happening at around 50 and 60 and continues to grow as we age. And it's responsible for all the issues that men complain about: getting up at night, weak stream, poor urine flow, all those issues.
So why, I mean, thank you for explaining that. I mean, so the prostate's not all bad, I guess. We really do need it, at least for a period of time. Why is it so related to the urine? Like, where is it located? That is it part of the urinary tract? Like, why does it have such an impact on urination, whether it's normal size or enlarged?
Yeah, so the prostate's location is deep inside the pelvis. It sits beneath the bladder and wraps around the bladder opening. So the bladder is like a funnel. It's a container that holds urine, and it drains down through a funnel. And around this funnel is the prostate, which wraps around it. like a scarf, so to speak. And so, and so that's its location, and it's there for a purpose because it taps into the urine channel where it allows the semen, allows the sperm to exit through the same channel that the urine does. So it's a valve that helps to control the what travels out of the urethra at any given time. Mm-hmm. But as the prostate begins to grow, it begins to tighten up and close off on that bladder opening and starts to restrict the flow. So its location is important for procreation, but it's also in a very delicate place because as it grows, it starts to affect how a person empties their bladder.
Got it. So like using your example, it kind of starts constricting and tightening up that funnel so the urine can't actually, has to go through a smaller and smaller opening to kind of get to where it needs to go.
Correct. And that makes it harder and makes the bladder work more, and that causes the problems that we're going to discuss further.
Yeah. So you had mentioned some of the symptoms to look out for. Everyone talks about BPH, but one thing I wanted to do today also is just really give men an understanding of what are those symptoms of BPH to kind of, you mentioned things like slow stream, but I know there's several others that are kind of, when men start having urinary symptoms, they're like, where's this coming from? So what are those classic BPH type symptoms?
Yeah. So as a man ages, they realize, gee, I'm not peeing as strongly as I used to. I'm having to pee more often, and it doesn't come out right away. So these symptoms are classic for when the prostate begins to affect the way you empty. And people say, yeah, I don't pee as well as I used to when I was younger. And why is that? And that's because of the prostate. So common symptoms that men complain about are slow stream, very weak. They say, yeah, I used to be able to pee like a racehorse and put out fires, but now it's like a drizzle, right? That's one. Getting up at night. They didn't used to have to do that, but now they get up 2-3 times a night, and this can be a problem for some men because it affects their rest. They're tired all day long because they have to pee. The stream doesn't start right away. It's called urinary hesitancy, where they stand there and it takes a while to come out. And they don't empty their bladder completely. They feel like when they're done, they still have some left over. They got to go back and try a second time. It can also cause other issues like urgency and frequency, where they have to pee multiple times a day, and they have to look for a bathroom. Otherwise, they're going to have an accident. So those are the common issues.
So the symptoms of like slow stream and starting and stopping, that all makes sense based on your funnel explanation, right? If you're closing off the hose and making it tighter and tighter, it's harder for that urine. You're no longer writing your name in the sand. You might be doing a few little Morse codes, and that's about it. But what about like that nighttime urination? What is it that about the prostate that makes men get up a lot at night?
So the prostate doesn't work in a vacuum. It's connected to a lot of other things. So the bladder is connected to the prostate, and connected to the bladder are the kidneys. So the bladder is a muscle. It's a muscle that helps that works together with the prostate, sort of like in tandem. Like they're like two dancers, two dancers like Ginger Rogers and Fred Astaire. They kind of work together and they evolve and adapt to one another through time. So as the prostate makes it harder for the bladder to squeeze, the bladder has to get stronger and stronger, and it becomes spastic. It starts to adapt to the demands that it's presented with, because the prostate is now creating an obstruction, so the bladder has to work harder and harder. And so that change in the bladder can cause the symptoms that men experience, the urgency, the frequency, due to the spastic behavior of the bladder. Also, the prostate doesn't allow a person to empty perhaps completely. So maybe they only empty halfway, and it doesn't take long for the tank to fill up again, and that triggers another urge to pee. So that can be responsible too. So incomplete emptying, triggering the frequent urination, can also be caused by neurological changes in the bladder. That is an adaptation to that increased workload.
Yeah, I mean that's actually a great explanation. It's as everyone listening can attest to. I mean, it can really affect a man's life. If they're running to the bathroom, they're spending so much time in the bathroom, they're not getting good rest. It's not solely as you mentioned, it's not just in a vacuum urinary issue. It affects so many different parts of their lives. Now, one thing that men often ask when it comes to any kind of condition is, "Am I doing something wrong?" Right? Am I eating something wrong? Am I drinking something wrong? Is there anything that I should avoid to at least to some extent help me with my urinary symptoms if we think this is the prostate and BPH?
Yeah, so for the most part, these changes are pre-programmed. These changes are not the fault of the man in terms of anything they're doing or eating and doing incorrectly. These are changes that are biologically programmed into a man's prostate. Some men begin to have these symptoms and start to have these effects early in their 50s. Some men, it doesn't happen to them until their 70s, and it's not necessarily related to, anything that they can change. I tell most patients it's not their fault that this is a condition that is biologically programmed into their body, and it's there's really no other way to prevent it other than to be aware that they're there, to seek assistance from a urologist to help alleviate some of those symptoms so you have a better quality of life.
Got it. So aside from not causing it, can things like a lot of men that you see online, they mention things like caffeine or alcohol, would that potentially make their symptoms worse though? Or would it not really impact too much?
It can. Certain habits can actually worsen their symptoms. So for example, caffeine is a diuretic. So it stimulates increased urine production. So if a person drinks a lot of caffeine throughout the day, then that caffeine kicks in during the night, and that wakes them up to sleep because suddenly their body is releasing more of the fluid within their body, called a diuretic. It's a medication that is given to help force the kidneys to empty more urine. So I usually advise people that if they're going to drink caffeine, to limit their caffeine drinks before noon, because it takes about 10 hours or so for the caffeine to really kick in. And if they're drinking it at noon or in the afternoon, then it kicks in around when they're asleep. The alcohol can also be an issue because alcohol it relaxes everything. It makes us feel nice and relaxed, kind of anxiety wise, but it also relaxes, the muscles in our body and the bladder, and that can make the bladder a little weaker so it doesn't empty as efficiently. I also advise people to if they like to drink a lot of water, to try to fill up their tank earlier in the day and try to limit their fluid drinking at nighttime so that they don't have to get up and pee throughout the night. So if they're drinking a big glass of water before bedtime, pretty much they're going to get up once or twice to empty that. So they can drink all of that in the morning, and then that way they get up less at night.
Yeah, I often hear men say that, they get up so much at night and they're worried they're going to get dehydrated. So what they do is every time they go and pee, they drink a little bit more to avoid dehydration. That's probably not a good idea in this case, I assume.
Yeah, I try to reassure them that the 6 hours or 8 hours that they're sleeping, they're not going to dehydrate. And if they fill up their tank, so they hydrate their body throughout the day, then they're going to be fine throughout the night. And if they do feel a dry mouth and a sensation to quench their thirst, then just take a little sip or to swish and spit, so just so they can relieve that dryness, but try not to gulp a large amount of fluid at night.
It's a great idea. Now, you had mentioned, alcohol as a potential drug that can, relax the muscles, etc. I know that a lot of men, when they actually have colds and flus, they take a lot of over-the-counter medications that then sometimes really put them in some dire straits with urination. Can you comment on that a little bit?
Yeah. So oftentimes I'll hear of a person who has a cold and he takes Benadryl or an over-the-counter decongestant. And he notices that the urine flow is a lot harder and slower. And sometimes in some men, it can stop the urine flow completely and cause urinary retention. So there are side effects. The side effects that help them deal with the stuffy nose it is called an anticholinergic effect. And so these drugs have that effect. And the anticholinergic effects are what dries out the nasal passages and helps them to breathe better, but it also causes a relaxation effect on the bladder muscle and makes the bladder muscle weaker, so that they have a harder time emptying their bladder. So in men who have active urinary symptoms, if they take over-the-counter cold medicines like Benadryl, Sudafed, those kind of medication, they can have a lot worse of a time urinating through the night and even maybe stop completely.
Got it. So good words to live by. I mean, I guess those men that have underlying urinary conditions probably should talk to their doctor before taking those over-the-counter medicines, I'm assuming.
I agree, yeah.
So, we outlined several symptoms that are kind of typical run-of-the-mill BPH symptoms: frequency, urgency, nighttime urination. Are there any, though, red flag symptoms that men might come across in addition to these, where they should start thinking, this isn't just BPH, I really have to talk to my doctor?
Yeah. So the symptoms that we mentioned are sort of like father symptoms. Okay, these are symptoms that affect their quality of life, and if it really affects them, they can seek assistance to help make it better, so they have a better time. But there are symptoms that raise more concerns, that maybe their symptoms, that their problem is further along than than they realize. One is having blood in the urine. So sometimes people have they see gross blood, they pee and they see red, and that usually causes alarm in a lot of people, so they come in for that. But other times, things like having urinary infections, for example. So someone says, yeah, I never used to get infections, but now I have infections which cause symptoms of burning pain with urination, bladder pain, fever, those kind of things. And so a typical man shouldn't be getting a urinary infection, hardly at all. But if they're getting it once, 2, 3 times a year, that could begin to cause a problem. Other symptoms, so hematuria, urinary infections, and sometimes men go for their health physicals, and their doctor checks a blood test, and that blood test can show elevation in a kidney function test called a creatinine, and the creatinine measures the health of your kidney, and suddenly they realize my creatinine is like higher than it should be, but I don't feel anything. I'm feeling fine. So sometimes the changes can be so subtle that can silently cause occult, or sort of that they're not aware of, injury to their kidneys.
And that's a great point. I mean, as we get old, when we're in our 20s and 30s, we feel pretty invincible, and there's no need to ever see a doctor because we feel fine. But to your point, I guess as men are getting older in their 40s, 50s, and beyond, that's kind of the importance of seeing a doctor, even for a regular checkup when you're not feeling anything. Because as you said, kind of behind the scenes, things might be happening without you knowing it that could be really impacting your health. So it's another great example of why, going for regular preventative checkups is so important in men and women for that matter.
Yeah.
That being said, one common issue that comes up is that men who have BPH symptoms, they might not even be so bothered by the symptoms as they are concerned, is this prostate cancer? Because that's what they hear about on TV all the time, and that's really what they're worried about. So the 2 questions, one is there any association between BPH and prostate cancer? And 2, does prostate cancer cause the same symptoms as BPH?
Yes. So the short answer is, I reassure men that prostate enlargement and prostate cancer are, as far as we know, are not related. One does not cause the other. They're separate conditions that can occur in parallel at the same time, and they just happen to occur in the same organ. And so, why is prostate cancer such a big deal? Because it's the #1 most common solid tumor, aside from skin cancer, diagnosed in men. #1 cancer in the US. It's the #2 cause of cancer death in America, behind lung cancer. So if caught early, prostate cancer is very treatable. If caught too late, not so much. And so that's why it's a #2 killer in men. Sometimes prostate cancer can present with the same conditions, because if the cancer grows and causes a growth of the prostate from cancerous growth, it can cause very similar symptoms that we've discussed in a man with a benign prostate enlargement. So these conditions are not related as far as we know. They can occur at the same time, and it's a challenge to sometimes, be aware which is causing what. And for that, we rely on a blood test called PSA. A PSA is a blood test called prostate specific antigen. It's a blood test that is done, oftentimes by a primary care physician. And if the numbers are elevated, it can indicate prostate cancer. It doesn't always, but it can.
And again, another great point about that. So, I mean, just the take-home message that I would get from that is that, if I have Bph symptoms, I'm not going to panic. More than likely, this is a sign of a benign condition. But at the same time, there's nothing wrong with going to your doctor and getting a checkup and just mentioning to him or her that you're having these symptoms, and they'll do all the right tests and reassure you, or maybe you'll find something that may not be so reassuring, but at least you can catch early enough to take care of it.
Right.
Very, very good point. Now, on that point, so, we talked about identifying the symptoms of BPH, which you did a great job kind of helping us understand. But now that as a man, if I'm convinced that, or at least I'm suspecting that I have BPH, maybe I went for a checkup to my primary doctor. They said everything is fine. But, I'm kind of weary or leery of taking medications. I like taking supplements and natural foods and whatnot. I know there's some supplements on the market they sell even in mainstream like Costco or supermarkets. I'll mention a few in a minute, but that we can talk about specifically. But in general, in your practice, are supplements something that you feel are a first line treatment for BPH, or do you feel they're really not moving the needle very much when it comes to helping?
Yeah, clinical studies have looked at some of the supplements, not all of them. Saw palmetto, for example, which is a very common supplement that men take for their prostate. And studies have shown that it's not any better than placebo for helping urinary symptoms. There are a lot of things we don't know about supplements. I mean, they're not regulated. We don't know what goes in them. They can make big claims on what the supplement can do, and there's really no regulation on all of that. But I try to keep an open mind with patients that sort of kind of do their Dr. Google stuff and find supplements that they think are helping them. So if they take a supplement, and I usually don't, I don't use supplements in my practice. But if a patient comes in with a supplement and they're taking it, as long as it's not something that is going to harm them, I usually try to keep an open mind and say it's up to you. I don't particularly use it. If it were that great, I'd be using it all the time, and I don't. So I don't see supplements changing the needle very much in terms of affecting the quality of a person's urinary function. But for some people, it's more they feel like they're doing something positive for themselves. So, and that's okay. They're paying attention at least.
Got it. So, just to dissect that a little bit and recap it, take home message: data doesn't really support tremendous improvement in BPH symptoms with these supplements. And the three supplements that I'll mention that kind of are mainstream sold in supermarkets, you mentioned saw palmetto, that's probably the most common one. Beta stiltostrol, after all these years, I can still never pronounce that. And pumpkin seeds, those are the ones that are kind of mainstream and sold in the supermarket, sold at Costco. Based on what you're saying, it sounds like not going to do a tremendous amount of good, but at the same time, if bought from a reputable distributor, somebody that you can trust, it's not going to do any harm either, which makes total sense. And again, if people feel that they're deriving some benefit from it, you're okay with it because of the fact that, again, studies haven't shown any harm from any of these three particular supplements. There are some supplements that to me are a little bit more of a black box, and they're, they are all over the internet. They're all over infomercials that you can't go on daytime television without hearing 4 commercials. And the ones I'm speaking of specifically are, and I'm sure your patients come and talk to you about it all the time, are super beta prostate and prostagenics. Now, if patients are coming to you specifically with those, and the reason I bring those up, those aren't just kind of random generic supplements you find in the supermarket. Those are heavily marketed specific supplements. What are your thoughts on that? What do you tell patients when they come to you with those particular supplements?
I kind of tell them the same thing that we just mentioned. I tell them that I don't rely on these supplements. And if they're asking me if I recommend a particular one, I usually don't have a strong opinion about it. I usually tell them that it usually doesn't work very well. I try to keep an open mind, because obviously these people, have their opinions, and so I tell them that, listen, if you want to take it and you think it's going to help you, then, but I don't think it's going to necessarily, replace some of the things that I do have that will work for you. I also try to keep an open mind, in the sense that there are a lot of things we don't know about about Eastern medicine. I mean, I'm trained in Western medicine, and I'm very ignorant when it comes to Eastern medicine. I mean, after all, a lot of products that we use come from natural occurring things. Aspirin came from the bark of a tree, and penicillin came from a fungus. And so there may be value, but there hasn't been enough research to validate the use of these things on a widespread level that I would necessarily embrace and advise to my patients that they take. And I think more research needs to be done. I tell them, it's up to them, but I wouldn't recommend it for my family necessarily if they asked me for it.
Good advice. Good advice. That's a very good point. Now, with something like BPH, which is mostly a symptomatic condition, the question inevitably comes up: when is the right time to see a doctor about this problem?
The right time to see a doctor is when it begins to affect your quality of life. Now, everybody is very different in this regard. Some people get up 2-3 times a night and they fall right back to sleep. Say, I'm fine with that. I've been living with it for years. It's not a big problem. And there are some people that get up once a night and they're miserable because they can't rest, they're unhappy. When it begins to interfere with your activities, when you have to plan your car rides, so that you know where the next bathroom is, or if you wet your pants and it's socially unacceptable. So when the problems begin to be, listen, I can't live this way, is when you should start, having that discussion with your family doctor or maybe with a urologist. We usually recommend for prostate health in general, whether you have symptoms or not, that men around the age of 50 should start to have, regular PSA tests and prostate tests, by their family doctor or by a urologist, even if they really don't have a lot of symptoms, just to sort of be on the safe side, because prostate cancer is so common and it's so treatable. Along the way, the doctors will probably talk to them about, the symptoms. Do you have any of these symptoms? And oftentimes, if a person just says, yeah, I do, but it doesn't bother me that much, then okay, let's back table that and talk about it, again, if it becomes a problem.
Good point. One of the biggest reasons that I started this podcast is that, as I'm sure you know, as a doctor who treats a lot of men, is that men are very skeptical about going to doctors, particularly when there's a looming thought of any kind of procedure or any type of exam. It's usually their partner dragging them in, or their symptoms are so bad they just literally can't take it anymore. So one of the points of this podcast is to really give men an understanding of, okay, if I decide to go see a urologist, for instance, I suspect I have BPH symptoms and I'm going to see a urologist, what should they expect in that visit? What kind of exams might you do? What type of tests might you perform? And I know this is variable and it changes from person to person, but on a high level, what's the expectation of a guy walking into a urologist office with BPH symptoms?
Well, it depends on the severity of their symptoms. And obviously it involves a brief discussion with the doctor, what we call history. And so we want to hear from them, from their perspective, how the symptoms are, how bad are the symptoms. We might ask them to fill out a questionnaire. We have a list of questions that will sort of assess their symptoms and kind of cue the doctor into certain points to look at. So if a person comes in and they're really not having too much problem, it usually involves just a brief discussion and then an examination. The doctor will probably examine their abdomen, examine their genital area just to make sure everything is okay, and then gently do a prostate check, which is a finger exam through the rectum to feel the prostate. It might also involve a blood test, a kidney panel test to make sure that their kidneys are functioning fine, looking for those silent problems that we mentioned, looking at their electrolytes, and also to look at their PSA to see if that number is in the appropriate range. And if any of those raise any red flags, then we have to pursue them further. But that's pretty much it. Just a quick talk, a quick examination, and a blood test. That's usually what's involved.
Got it. And that's helpful. It doesn't sound terrible. If you're going to get some relief at the end of that, that certainly doesn't sound like a terrible initial evaluation. And as you as a doctor, when you're doing this evaluation of a guy walking in the door with Bph symptoms, are there any other conditions that could mimic Bph that you're trying to rule out, that maybe this guy's symptoms aren't actually prostate related?
Well, it really depends on their symptoms. Obviously, if they're having pain and fever and things, then you would think of inflammation or infectious process. If it's sort of like the grievances are just sort of the bother symptoms, then it's most likely Bph. But we're looking for things like prostate cancer. If there's blood in the urine, it could be bladder cancer. If they're having any kind of pain or discomfort, it could be from prostatitis. It could be from a urinary tract infection. It may be even caused from an STD, sort of a chance sexual encounter that could have caused it. So those are the main ones.
That's a good point, because again, you can't always, I guess that's the benefit of going to the doctor, is that you can't always just assume that just because you have Bph symptoms, you have Bph. And sometimes a quick evaluation by the doctor can really help differentiate that for you and put you on the right path. And speaking of the right path, then, so let's say again, you've seen a patient who has Bph symptoms. You're fairly convinced that they do have Bph, and they're bothered enough that they say, Dr. Bowie, I need help. What do you do? Is there a certain set of medications that you might rely on to treat the prostate, or are there different kinds? What's your approach with medications for Bph?
Yeah, so if a patient is saying that they need some help, then the first thing that we talk about is our medications. These are our prescription drugs that we can prescribe that will help alleviate some of the symptoms. One of the type of drugs is called an alpha blocker, which is common names is terazosin, Hytrin, Cardura, Uroxetrol, Tamsulosin, Flomax, Rapaflo. So these are different versions of an alpha blocker, and the job of this drug is to relax the prostate. The prostate is a smooth muscle. And so if you can relax the prostate, urine flows through it much easier. So that's one type of drug that can be used. A second type of drug is called a 5-alpha reductase, which is drugs that go by the name of Proscar, finasteride, Alvedar, dutasteride. These work in a different way to help shrink the prostate. And so studies have shown that if a man takes an alpha blocker and a 5-alpha reductase together, they both function better than either of them separately. So I usually tell them that these are the drugs that are going to work the best. But we also have a very in-depth discussion as to sort of the side effects, because these drugs are not without side effects. And so we have a talk about that, and then they have to weigh the facts on what potentially could be the side effects and how that could improve their urinary function.
Got it. So just to kind of take a step back, so you mentioned two classes. One are alpha blockers and one were 5-alpha reductase inhibitors. You mentioned, I believe, that alpha blockers, they work by, if you will, again, going back to your initial analogy, loosening the funnel, opening the channel a little bit, allowing that tightness to loosen up and allow the urine to flow out easier. I didn't think I caught, how does the other class of medicine, the 5-alpha reductase inhibitors, do they work the same way, or they have a different mechanism?
No, they work by a different mechanism, and they work by shrinking the prostate, by actually reducing the size of the prostate. And so those two pathways are synergistic in terms of helping the prostate, help you urinate much better. Now, there is another kind of drug that's often used. It's called Cialis.
Right.
Cialis is a drug that we often associate with erectile dysfunction, but studies have shown that if you take Cialis or its generic version, tadalafil, at low dosages of 5 milligrams a day, that it will improve a man's flow. But in my practice, I've noticed that this does help, but not to the same degree as the alpha blockers. But it can alleviate a man who comes in with milder symptoms and is concerned about the side effects.
Got it. So and that's an important point, because a lot of men are hearing this about daily Cialis use for BPH, and they go to their doctor and say, I want to use it. But just to recap, it sounds like Cialis is, the effects on BPH are a nice added benefit for men who take it for erectile dysfunction, but you wouldn't necessarily recommend that as a first line therapy for men with significant BPH symptoms, like that are really bothered by it.
Correct. If a man comes in and during my examination, it's clear that his symptom score, this questionnaire is very high, and he expresses a lot of those symptoms that we discussed about. And there are signs that maybe he's not emptying his bladder well. We often do a bladder scan to see how well he empties, or a uroflow to verify the flow. And we see that his symptoms are severe. I would not necessarily recommend Cialis right off. But if the symptoms are mild and they want some relief, then it's reasonable to consider Cialis, for milder conditions.
So you had mentioned very importantly that all these medications for BPH do come. There's no free lunch. They come with their own list of side effects, and that's particularly important because BPH is a lifestyle condition, and the side effects of a lot of these medications also impact your lifestyle and your daily well-being. Let's start off with these alpha blockers, these medicine that open up the channel. Right. What kind of side effects should men expect? I mean, not all men, but what can they expect from when they're starting to take an alpha blocker?
Well, sort of the biggest difference that these men will notice is in their sexual function. The one known side effect of these alpha blockers is it causes what we call retrograde ejaculation. It's when a man has sexual relations, they'll notice that they make very little semen that comes out during intercourse, and that can sometimes be alarming to them if they're not aware that this is a known side effect. So the prostate, this medication relaxes the prostate so much that it doesn't close the bladder door, and so the semen, as it's being produced, can flow into the bladder, the path of least resistance, so to speak. And then as a result, they don't see a lot of semen come out. And so I tell people it's mainly the direction of the flow. It's not a contraceptive, and I tell them they can't be a porn star anymore. So that's that. Usually lightens their mood a little bit. Some men do say that the quality of the orgasms are not as good, but for the most part, if they're aware that the semen is not going to be there, then it's not a deal breaker for most of them. The other side effect that I tell people to be aware of is that it can have some blood pressure effects on them, mainly when they're changing their position from a lying down to a standing up position. The blood pressure can be slower to compensate, and some men can be dizzy, and it can even make them pass out. So they have to be aware that could happen if they get up at night, to get up slowly and to sort of assess how they respond to it. And sometimes the effects are so prominent that we have to have them stop the medication.
That's important to know, especially you don't want people passing out and hurting themselves for sure. But I know in my experience that the side effect that catches their attention much more is the retrograde ejaculation than the dizziness. It's usually, yeah, great about dizziness. Let's talk more about the retrograde ejaculation. So about that, two follow-up questions. One is that we hear a lot is, okay, the semen's not coming out. Is that dangerous to me? Is it getting blocked up in my body? What happens to it?
Yeah, so it's not dangerous. Basically, it's going to the bladder, and then when you urinate, it gets flushed out. So in some cases, in some of my patients that need to be on the medication and they still want to conceive, that a reproductive specialist can even harvest the sperm from the urine sample, spin it out, and then can use it to inseminate a partner. So the semen is being made. It's just going a different path. It's not dangerous. It's not harmful, and it's reversible. If they stop the medication, then it goes forward again. So when the other important thing I tell patients is they ask, how long am I going to be on this medication, and what if I have side effects? So I tell them this is a long-term treatment. This is not a short term in terms of months. We recommend the medication, and it can work for several years, but there's a point at which it may stop working, at which we have to entertain other options. I also tell them, listen, when I prescribe a medication, you're not signing a lease or a mortgage. I'm recommending it because I think it'll help you, and if it does, you continue it. If for some reason you don't like to take the medication, or you just don't like to take medications at all, then you can always stop it. There's no forced decree to take the medication.
That's very reassuring for sure. You always worry, hey, is this my only path? Meaning there's no going back. Now, one other side effect that sometimes it goes around the internet circles with these medications is erectile dysfunction. You had talked about Cialis as a treatment for erectile dysfunction to help Bph, but some men, particularly with tamsulosin and Flomax, they complain about it impacts their erections. Have you seen that in your practice?
Yes, to a certain extent. The tamsulosin normally doesn't affect the erectile dysfunction. It's more the other class of drugs, the 5-alpha reductase, the finasteride and the dutasteride. With finasteride, I tell them there's a small percentage of men, about maybe 3 to 5%, who report that their libido isn't as good, and as a result, their erections are not as strong. And it affects the men who already have sort of weak erections to begin with. The other drug, though, Avodart, does have a higher incidence of anywhere between 10 to 20% of its effects on erectile dysfunction. So, we have to sort of tell them that because it can be an issue for these people.
Got it. So just to recap there, with the alpha blockers like tamsulosin, erectile dysfunction, not that big of an issue. Retrograde ejaculation, much bigger problem there. And moving over to the 5-alpha reductase medications, which are more hormonal drugs, right? They affect the hormones. Erectile dysfunction is something that definitely comes up a lot, no pun intended, with this medication. Any other side effects that you counsel men on with taking these 5-alpha reductase inhibitors?
Yeah, so there's always a controversy with regards to prostate cancer. There've been some men read the labels, they go online, they say, well, these drugs cause prostate cancer. So it's a debate in the field of urology. And so the issue is that when these drugs were studied, and they were the company that made the 5-alpha reductase inhibitors were trying to push the indication to taking these drugs to prevent prostate cancer. And so they studied these effects. And what they found was that in men who took 5-alpha reductase inhibitors like finasteride, there was a significant reduction in prostate cancer. However, in men who got prostate cancer while taking these drugs, there appeared to be a more aggressive version of prostate cancer that appeared when they took the drugs. And so men worry about the relationship with this drug with prostate cancer. And so I try to reassure them that these studies probably indicate a sort of a kind of a microscopic change in the way the tissue looks that makes it look more aggressive. What we do know, though, is that in men who get prostate cancer with or without finasteride, that the cancer doesn't seem to cause any increased death. So it's not more deadly. It just looks more aggressive, but it doesn't behave as a more aggressive cancer because men don't die any faster than those that don't take finasteride. So what the interpretation there is that the hormonal effects cause so much shrinkage of the prostate that it affects the milieu, the architecture of the prostate that makes it look more aggressive. So if there is an indication to use it for the intended purpose that we're talking about, then it's safe to use. But if a person comes in and says, listen, I want a drug that will help prevent prostate cancer, then we don't recommend these drugs for prevention of prostate cancer.
That's actually a great explanation, because a lot of men do read about this, and it comes up on the internet quite a bit about that historical discussion about the relationship between these medications and prostate cancer. And I think most urologists probably agree with you in terms of that take on it. Now, some other side effects that have kind of come up with these medications. One is, you had mentioned erectile dysfunction. What about the libido itself? Just like, the sex drive. Have you noticed that in your practice? A lot of men complain that they just don't have the interest in sex as much with this medication.
Yeah, I do. To a lesser extent, with finasteride, anywhere between 3 to 5% say that they're not as interested in sex, and anywhere between 10 to 20% with dutasteride. So yes, now the mechanism of why that happens is unclear, because if you understand the mechanism of how these drugs work, is that they prevent the conversion of testosterone, which is a hormone that's produced by the testicles and regulates a man's libido. They prevent the conversion of this hormone in the tissue to a more potent version called dihydrotestosterone. Now, this only happens in the tissue. The overall level of testosterone in the body is unchanged. And as far as we know, dihydrotestosterone is only a tissue effect. How that relates to a libido is not clear, at least I'm not clear on how that works, but there's no doubt it does have an effect on a man's libido. And for a lot of reasons, for these reasons, some men just can't tolerate it because they won't accept those effects on their sexual function.
And I guess that really goes back to that your first statement about the prostate being a reproductive organ, right? It's just that vital connection between the urination, erections, reproduction, etc. Really, there's trade-offs involved, right? So again, there's no free lunch when it comes to the prostate. That a lot of men come to realize that we can help with your urination, but there might be some side effects associated with it, and men need to be prepared for that. So I'm really glad that you brought those up. One other fairly rare one that I just want to bring up, just to be complete, is growth in breast tissue size. Something that doesn't happen very often, but when it does, it could be pretty devastating, at least from a psychological perspective, if nothing else. Have you had experience with that in your practice, and what are your thoughts on it?
Yeah, I've heard from some men that these drugs will make their breasts grow, and that it's not a common finding, but it does occur. And when it does happen, it's distressful for these people, and they have to stop the medication, or just they won't accept those changes, and it's understandable why. So yeah, that's a known side effect that can discourage men from taking the medication that could help their urinary function.
Got it. So now I'll bring another scenario to you. You're that patient that first came in with the Bph symptoms. You started him on some medication. Maybe you increased the dose. He's maxed out. He's taken all the medication, and it's either not working, meaning his symptoms aren't sufficiently improved, or let's give the scenario, he can't take the medication. Any one of these side effects we just discussed were too much for him, and he says, doc, I got to stop. Where do you go from there?
So then, we do other assessments as well. We just, make sure that their urinary function is safe, that there isn't any negative effects on their kidney function. But usually when a man fails medication, or doesn't want to take medication, or can't take it because of side effects, then we have to talk about more proactive options. In the past, the only other pathway was surgery. where we would have to operate on the prostate to reduce that prostate size. But in the past 4 or 5 years or so, there have been more office-based interventions that we can offer these patients that can provide urinary relief. And I'll mention a few. One is called Urolift, and the other is called Resume, which is a water vapor therapy. These are the most common ones that we do in the office. They take 5-10 minutes. They can provide quick, relief. And surprisingly, a lot of the patients who undergo these office-based procedures can avoid surgery and come off all their medication.
That sounds very impressive. Just to give the listeners just an idea, you said it's like a 5-10 minute procedure. Like what's involved? I mean, I know obviously that I'm assuming there's some invasive nature to it. What's involved on a very high level, not going into too many details, like what's involved in these procedures?
Okay, so basically a patient, we have a thorough discussion regarding their expectations. So I tell them the technique itself. The Urolift is a 5-10 minute procedure where the urologist gives the patient a local anesthetic or a gas anesthetic or something to help them get through the procedure, but it takes about 10 minutes to do the procedure. The urologist inserts a little camera through the penis channel and is able to visualize the prostate. And in the concept of Urolift, these implants, these little anchors are deployed, which helps to pull the prostate apart and widen the channel, sort of like pulling up a circus tent to help create a wider path for the urine flow. In the treatment of Resume, a special needle is deployed that can inject a little puff of steam into the prostate tissue, and that causes the prostate to shrink and open up the channel. The procedure takes 5-10 minutes. They go home the same day, and there can be a delay of a week or up to 10 weeks for some of these treatments for them to reach maximum effect. I have a discussion with them about the pros and cons of the treatments. Do you want me to get into that, or
just on a high level, just to explain, just to kind of to know what they're getting into? I know, at least from a high level perspective.
Okay, so from a high level perspective, I tell them that the gold standard is surgery. The common surgical treatments are a transurethral resection of prostate, also known as a TURP, commonly referred to as a roto-rooter. This has been the gold standard. It's the surgery. It takes 90 minutes. It requires a hospitalization with a general anesthetic, sometimes an overnight stay in the hospital. But the benefits are that it works mostly all the time, and it lasts for 10 years. Okay, but with any surgery, there's always risks involved: anesthesia, bleeding, infection. With an office-based procedure, you avoid the invasiveness of the surgery and the hospitalization. The benefits of the Resume and the Urolift is that there's very minimal effects on their urine control, called incontinence. So there's minimal effects on incontinence. There's very little effects on their erectile dysfunction, so it doesn't affect that. And the majority of the patients can come off their medication. The negatives of the procedure is that it doesn't last as long. The typical time frame for Urolift is about 3 to 4 years that it can provide relief. The symptoms will likely come back and need to be treated again or by some other modality. The Resume can get a little bit longer, maybe 4 to 5 years of control, but they're not as long as the traditional surgery. That's
and
it.
Just taking one step back, when we're talking about the roto-rooter, the TURP, the gold standard procedure, you had mentioned, the big risks: bleeding, infection, obviously risks of anesthesia. You had mentioned in comparison, there's a small risk of erectile dysfunction. Is that very high? I mean, is that similar to like when you have prostate cancer surgery?
No, not at all. The sexual function risk from a TURP, the main one is the retrograde ejaculation. Okay, so after the procedure, a high percentage have retrograde, and it's not a reversible retrograde. It's more of a long-term problem. in terms of impotence, erectile dysfunction, it's less of a worry with a TERP because all the nerves that control erections live on the outside of the prostate, and when you work on the inside of the prostate, there's less effects on the nerve. So I generally tell men that their erections are not affected with a TERP, but there are a small percentage that will report their erections are weaker after a TERP. Mechanism, I'm not sure. Maybe they're already weak to begin with, and now it's more prominent to them. They're more aware of it. But the retrograde ejaculation is a high risk.
And you had mentioned, again, with Resume and Urolift, you mentioned another advantage is no real risk of incontinence or leakage of urine. Is
Right.
that a significant consideration for TERP or Roto-Rooter?
Not a significant risk at all. It's about a 1% risk. And so a 99% chance that's unlikely to be the case.
Got it. So pretty small consideration. Now, one thing I don't remember if you said or not, I guess one of the big marketing value propositions for Resume and Urolift is the fact that unlike TERP, they don't cause retrograde ejaculation. Is that the case? I mean, in your experience or in the literature, is that really been proven out?
In my experience with Urolift, very low rate of retrograde ejaculation. However, in Resume, in my patients, I've seen retrograde ejaculation occur, especially when there's a very dramatic shrinkage that can occur. And so I hardly ever see it with Urolift with retrograde ejaculation, but with Resume, I quote men about a 20% risk of it happening and 1 in 5 risk.
Got it. Still much lower than TERP because, again, as you mentioned, for TERP or Roto-Rooter, the expectation is basically 90 to 100% chance, right? That almost all men will have, because that's not only a risk, that's an expectation for those procedures. And the difference is that you're going, if you will, all in when you go with TERP or Roto-Rooter, because as you mentioned, very importantly, if you take a medication and you have retrograde ejaculation, you stop the medication, the retrograde ejaculation usually goes away. Surgery, you can't put pieces of the prostate back, right, to reverse that retrograde ejaculation. So very, very important point. Now, just in terms of a little bit understanding of post-surgical, like a recovery. So you're talking about first the TERP or the Roto-Rooter. You said some men might stay overnight, some will go home the same day. Do they have to have a catheter after the procedure?
Well, it's based on the urologist, and their approach. In my practice, I generally send people home with a catheter for a few days, and I didn't used to, but you don't have to. So if a patient's able to urinate after a TERP, then and they're not bleeding, then you don't have to use a catheter. But in my practice, I tend to use a catheter for a few days just so I can have a handle on their hematuria. Okay, because there's nothing more distressful for a patient than to not be able to urinate and to not know why and to have that problem. So, with a catheter in place, it kind of relieves the patient and the doctor a little bit in terms of what's going on. So if there's a lot of blood coming out, then obviously the patients are aware but don't need to be rushed to the ER for retention. So I generally use a catheter after a TERP for about 48 hours, 2 to 3 days, and then take it out calmly in the office. But you can also do it without a catheter too.
So let's assume they have a catheter, they come back to the office in 3 days, and this is after the TERP or the Roto-Rooter. When you take out the catheter, should they expect immediate symptom relief? Meaning, should they expect to be writing their name in the sand again? Or like with those other procedures that you mentioned, is there also a delay, like of 1 to 10 weeks in terms of when they feel like they could really pee like a racehorse, if you will?
After the TERP, generally people have a great mechanical flow, meaning that the urine flows very quickly, very easily. But what they experience is sort of a 6 to 8 week period of irritation, because that prostate area has to be shaved. It's sort of like scooping ice cream out of a bucket. You're taking little chips of prostate tissue, and that surface is raw, and so it can lead to irritation. And so the way I explain to patients, it's like like when they were little and they would fall and scrape their knee and water would splash against their wound, it would sting a little. That's sort of how it feels. So I tell people that for about 6 weeks or so, you need to watch what you eat and drink. Certain foods will irritate the bladder, spicy foods, caffeine, alcohol, garlic, onions, and tomatoes. Those kind of things will really irritate and sting, cause bladder spasms and things like that. And that can, it takes about 6 weeks for that outer skin to grow back and to kind of seal off that area of surgery, so that, and then after that period of time, no more burning, no more irritation, only great stream.
Got it. So regardless of whether you go TURP, Roto-Rooter versus Resume or Urolift, it's not going to be instantaneous. There's going to be some recovery time, if you will, of several weeks until they reach that steady state where they're really going to know what their outcome is truly going to be like.
Well, with a TURP, the flow improvements are immediate, but the irritation is about 6 weeks. With Urolift, however, the improvements are more immediate, because it's a mechanical change, and they don't have a lot of irritation because you don't have to scrape the tissue. So Urolift does give you a more immediate, within 1 week, 2 weeks, they're peeing much better. With the Resume, however, the Resume takes about 8 to 10 weeks for people to really feel the improvements, because it relies on the body to clear out some of that prostate tissue that's been treated with the water vapor, and that doesn't happen quickly. So I tell people after Resume that don't expect your flow to be better immediately. It can take 10 weeks for that to happen. With Urolift, you can get a quicker improvement in your flow, but the effects may not last as long.
Got it. And so another question I have is that you had mentioned at the very beginning, TURP, Roto-Rooter, gold standard. Resume, Urolift, newer, have benefits. Tough decision for a guy to do. And let's say these other ones, the Urolift and Resume, they sound better. I want to try them. But let's say they don't work. Can I still get the gold standard afterwards?
Absolutely. So I tell them, listen, you don't burn any bridges. If you choose to do the office-based procedures, there's a good chance they'll work for you, at least for a finite period of time. And then you can table the options later on and reconsider if you want to. If it doesn't work, if you happen to be the 20% that it isn't improved, then you could still have the gold standard treatment later on.
Got it. Last question about Resume and Urolift. Newer procedures haven't been around that much. If a guy is shopping around, they say, you know what, this sounds good for me. Do they need to keep anything in mind with who's doing their Urolift? Now, I mean, obviously, or Resume, obviously you have a lot of experience with them, it's pretty straightforward, but should they be asking questions of the surgeon doing these procedures in terms of experience, or is it pretty like a straightforward thing, like you get a vasectomy from any urologist, it'll probably be okay? Is there a certain art to this? Should they really be asking specific questions of a potential urologist that's going to be doing these procedures for them or to them?
Yeah, I mean, to a certain extent, it's not as involved as searching for a robotic prostatectomist, someone who does the robotic surgery. I mean, these procedures are not technically that complicated, and I think it's a general. It suffices to say that the patient should feel comfortable with the doctor and his explanation. And obviously, you want someone who's not doing their first one. And someone who has years of experience, but this technology is only about 4 or 5 years old, so it's not something that you're going to necessarily find people who do a lot. Although there are some people that have done countless number, but because this is all they do. But it doesn't mean you won't get as good of a result from someone who does fewer. But it obviously you have to feel comfortable with their explanation. You have to have a clear a detailed explanation for what your expectations will be from the procedure. And I think if a surgeon can convey those kind of things to a patient to make them feel comfortable, then I think that there shouldn't be a problem with the urologist doing it. Again, it's not a very complicated procedure, but it's the general sort of discussion that needs to happen before the decision is made.
Great points. One last question about procedures in general. One procedure we didn't talk about too much is laser procedure of the prostate. Particularly, there's a procedure I understand with Holmium Laser called the HOLEP that a lot of patients ask about. A lot of men hear about on the internet. It's kind of a, if you will, a rival to Roto-Rooter or TURP. Probably not as much of a rival to the newer procedures in the office. What are your thoughts on laser treatment, and how would you describe them, and what would you tell to men that might ask you about them?
Okay, so laser therapy sounds sexy. It sounds, new and everything, and it is relatively new, but it falls into the area of sort of the more aggressive type of treatment, like in the class of the Roto-Rooter. So the Roto-Rooter, it accomplishes the same goal in terms of removing prostate tissue. It just uses a different tool. Instead of using a sort of an electrical loop that scoops the prostate tissue out, you use a laser to try to either vaporize the tissue or remove the tissue from the prostate. So it falls into the same class as the Roto-Rooter. It's just a different selection, a different tool that's being used. There's two kinds of lasers. There's a green light laser and there's a Holmium laser. And so the green light laser vaporizes the tissue. It's sort of like a lightsaber. It kind of cuts the tissue and seals blood vessels. Very effective, and it's a tool I use quite often. There's also the Holmium laser, which is a little different technology that also vaporizes the tissue, but can also cut the tissue as well. So people can use it to carve the prostate out of its current location, core it out, so to speak, and then remove it in pieces later on. All three modalities are effective: the Roto-Rooter, the green light, and the Holmium. It really depends on the experience of the urologist and everything. Some urologists are very, very good at TURPs, and some urologists are very good at Holmium. Some are good at green light, and in the right hands, whatever tool is chosen is going to deliver on a good result. In the competent hands.
Got it. So more along the lines of the bucket of the Roto-Rooter or TURP, and very, very important point. You'd much rather have a urologist feeling very comfortable with the procedure they're going to do for you. Probably be vastly better than something that they've just picked up. That's for sure. Well, that's all our BPH questions for sure. And thank you so much for providing such insights. I'm gonna leave though with the question that I ask all of our experts here, because you haven't gotten to where you are just by knowing about BPH. You know a lot about life as well. And as the name of our podcast is Better Man Clinics, the question I have for all our experts is, what's your key to success? What's your secret to your best life?
I think the secret is to be honest with yourself. Okay. And I think that, not to ignore, just to be honest with yourself in all aspects of life, whether it's with your health, or whether it's with your job, or with your relationships. I think that, because at the end of the day, you have to wake up. I mean, you have to look at yourself in the mirror and wake up every morning and see yourself, and you have to like what you see. So I think that you just have to be an honest person and kind of be a straight shooter.
I think that is very, very wise advice, because truly, how can you improve on yourself if you don't know what to improve on? Correct?
That's right.
So with that, Dr. Bowie, thank you so much for your time, and for everyone listening, thank you. And remember that your best self is a journey and not a destination, and use every day to make yourself just that much better. Thank you, and we'll see you next time.
Thank you.